Hello, and thank you for taking the time to participate in this presentation of the review of the COVID-19 virus and its ramifications for the rural healthcare providers in America. This presentation is a collaboration of HeartCare Imaging and Praxis-ID. HCI has a passion for the rural healthcare marketplace, and we have been providing needed diagnostic services throughout the USA for the past 22 years. HCI and Praxis-ID share the vision of supporting and improving rural healthcare, which has brought us together for this valuable presentation. And we are doing it as a public service for our friends in rural healthcare America. The goal of this webinar is to allow the participant to, 1, understand the basics of the COVID-19 virus, 2, provide an accurate and up-to-date look at the impact across the globe, and finally, to provide the education to prepare rural healthcare providers to confidently address the issues of caring for COVID-19 patients, as well as handling the potential unforeseen number and variety of patients will not be able to be transferred due to the overflow of COVID-19 patients at the regional and urban hospital centers. At this time, I'd like to introduce the founder of Praxis-ID, Dr. Ramzi Asfour.
Hello, everybody. Thank you for joining us for this presentation. And thank you, Bob, for introducing me and partnering with us to help those of you in rural communities deal with this situation. We have been working in rural health communities for quite a number of years. I'm the founder of Praxis Infectious Diseases, and we have a lot of experience in rural communities in the United States and have been helping critical access hospitals in particular, but also smaller community hospitals for a number of years. We have some experience between us at World Health Organization, and we're all board certified in infectious diseases. Infectious diseases is a great field in which to have telemedicine. You can do a lot without actually examining and physically examining the patient. So that's what lends it to being quite good in that regard. We all have a background in some teaching. We help with infection control, infection prevention, and we are founded on telehealth principles. And our goal, our essence is to help those of you in the rural communities deal with all kinds of situations related to infectious diseases, as many of you are not able to employ a full-time infectious disease physician. We help with antimicrobial stewardship, we help with infection prevention, pharmacy support, and we provide an integrated model of service linking infection prevention, antimicrobial stewardship, and patient consultation. We wanted to talk certainly about COVID-19, which is on everybody's mind these days. And I wanted to start by showing you the CDC travel warnings, which have been increasing of late. And I think yesterday there was another warning where you're not supposed to travel outside of the United States. And if you're an American and you're not in the US, either get home now or stay in place because of all of the transmission and spread of the infection. Worldwide. This is a summary of worldwide cases as of March 19th. This is from the coronavirus tracker map at Johns Hopkins. The website is a great reference for lots of information about coronavirus. You can send it to your patients. It's mapping activity in the United States and across the globe. And as you can see, there's hardly a country that is not affected. One of the things that we're prioritizing is flattening the curve. So our health, and that's, you probably all have read about that. That's very important in terms of maintaining healthcare system capacity. Even with these measures, however, we are likely to exceed healthcare capacity in the United States, especially in the larger centers. A lot of our rural hospital colleagues have noted that a lot of you actually have some excess bed capacity, perhaps not the staffing to go with it, but that's where a lot of spare, quote unquote, spare health system capacity is in our healthcare system as a whole. And we're going to have to think about that and how we can utilize those beds to help us manage the tremendous number of cases that we're going to have in the next few weeks. So just making this a little bit more personal, what can we do to protect ourselves? There's been a lot of misinformation. There's been a lot of other information. What can we do? So some of the things we can do are, and that people have talked about, and we're not supposed to do that in the United States, is wear masks. But some countries, some settings where Joe or Jane public has worn, they've been wearing masks in Taiwan and Singapore, Hong Kong, South Korea. That's their culture from the SARS epidemic. Many years ago, they were wearing masks, and they got used to wearing masks to prevent infection. And the question is, does that work? Well, it probably helps to some degree, and that's the truth, but that's not what our health authorities are saying, for good reason, because we have a shortage of PPE. So we're going to use the masks where they're more important, where they have more benefit, and that's for droplet precautions, for example, inside the hospital, and not everybody going around wearing a mask. Because in our setting, we have to take a public health approach, and that's what makes the most sense. Also, gloves at home. How do you use gloves? When do you use gloves? Alcohol-based hand sanitizer, you can find it still in most hospitals, but even that's scarce in some facilities. And you can actually make your own using some recipes that you can find online, making sure it's at least 60% alcohol content. So a lot of people are doing that. Hand washing is important. 20 seconds, remember, is longer than you think. In the hospital, I almost never see anyone wash their hands for longer than 20 seconds unless they're scrubbing into the OR. And keep in mind that friction is key, even with hand sanitizer. So you really want to have that friction, rubbing your hands, going through, even with hand sanitizer. Don't forget, don't just put the hand sanitizer on your hand, do like this and you're done. No, you need to rub that through your hands and on your hands until it's dry. Cleaning your phones. The people always joke, what's the dirtiest part of the doctor? It's their phone. That's actually dirtier than the stethoscope. So keep that in mind at home. When we go out to a grocery store, a lot of us don't want to touch the pen that's there on the checkout stand. I'm using Apple Pay or Google Pay or those kinds of contactless payment systems as much as possible, so we don't have to touch those devices, but you're touching your phone all the time. So when you get home, wipe down your phone. What do you do when you get home from the hospital? When you're faced with patients with COVID in your facility, you might want to, and it depends, you have to risk stratify here. So if you have high-risk people, for example, older people, maybe with lung disease in your home, you might want to be super careful and take off all of your clothes down to your skivvies in your garage, for example, put them in a bag, launder them, or collect them for a couple of days and then launder them at the same time, and then hop into the shower. So that's something to think about. Wash your face cautiously. If there's any virus on your face, you don't want to rub it into your mucous membranes. And then people always ask, how long can this live on surfaces? Certainly on harder surfaces, it can live longer than soft surfaces. So cardboard isn't a major risk factor. What should I do when I get a delivery? For those, again, risk stratification plays a role. If you have a high-risk family, you might, if you're getting takeout food, for example, you might leave the takeout bag on the doorstep or outside your front door, take out the contents, put all the food into Tupperwares, for example, and then dispose of or recycle the containers and keep them outside. And when you go to the trash the next time or recycling, you take them down with you, and then you wash your hands, and then you enjoy your food. I don't think, for the most part, that food is a major mode of transmission. People always ask, what if somebody sneezed on my food? That could be concerning, but again, it's probably not a major mode of transmission. So we also have to be rational and calm and take appropriate and reasonable precautions. And what about socializing? In some areas, schools are closed. My daughters are out of school. they're asking, can they go running with their friends? So that's a good question and generally frowned upon at the moment. However, socialization is important, so we have to have a balance. So if everybody at both households is healthy and the friends maintain a safe social distance of at least 6 feet, then it's probably fine if they go running together. And what if you have elders at home, then you need to be perhaps a little bit more cautious. So just to talk a little bit about characteristics and practicalities of coronavirus infection, this is a study published in the New England Journal. It's still poignant, talking about what the clinical criteria were or clinical characteristics were of the people that were admitted with coronavirus to in Wuhan or diagnosed. So most of these patients have presented to a hospital, and the median age was 47. You can see that that's not very old. And if you look here, this is the disease severity, and so severe disease. And the presence of the primary composite endpoint was admission to intensive care unit or death. So I'd just like to focus on this column and this column for ease, but keep in mind that of the 50 to 64 age group, that was 28% of the patients, almost 30% of the patients, and 15 to 49 was 55%. But if you look at the severe, it was only 18%, but that's still a large number of 15 to 49-year-olds that were affected. And 50 to 64-year-olds were 32%, and over 65 was the majority, or barely the majority, I mean, just under 50%. And then in their study, 32% were females, but we're finding that women account for roughly half of the cases at this point in the United States, although all these numbers are subject to change. So this is just a general guideline. And if you looked at never smokers, even in the severe group, 2/3 of the severe group were never smokers. Also, fever on admission, we always talk about fever being present on admission in these cases. It was only present in less than half of patients. So keep that in mind. They might not have a fever on initial presentation. Also, just sore throat and congestion. So the interesting thing that everybody's been talking about is nasal congestion or coryza, which includes conjunctival congestion. These are not common findings. So less than half, and in the severe group, 3% had nasal congestion. So nasal congestion is reassuring. You know, my daughter was home recently and she had a cough with a runny nose. Can't reasonably get her tested for COVID at the moment in a reasonable time frame, or at least couldn't last week. And so I didn't test her, but I also had the clinical clue that she had a runny nose, which is not common here. Cough in only 67%, so it's a little bit more than 2/3. Even in the severe disease, there were, not everybody had a cough. So keep that in mind. Chills, myalgias or arthralgias, not super common, especially not in the severe disease. GI symptoms, nausea, vomiting, diarrhea. So people are talking about that. It does not seem to be predominant. Sputum production in about 1/3, and less than 15% have a sore throat. So these are signs of infection. Really nothing to take home about here. It's very difficult to tell by examining somebody if they have this disease or not. And any coexisting disorder, so most people, 58%, but only 58% had a coexisting disorder. That means over 40% did not. And those disorders were COPD, diabetes, hypertension, coronary artery disease. And I would say that uncontrolled diabetes, uncontrolled hypertension, or severe cardiovascular disease are certainly risk factors, as of course is COPD or emphysema. And we're also finding that cancer is a risk factor, and having had chemotherapy for cancer is a risk factor, even for younger patients. So on the next slide, we have laboratory findings, and this is also interesting. The take-home point here is that most people did not have a leukocytosis. So if you have a patient with a leukocytosis, it's not likely to be COVID. Look at this line here with a white blood cell count of over 10,000. There were only 25% of patients with severe disease had that. So even with severe disease, we're not seeing a significant leukocytosis. But if you have somebody who's not severe on presentation and they have a leukocytosis, and we'll talk about some other factors in a minute, we can use that to risk stratify some of our patients and decide on the use of our precious supply of PPE. We also can look at some other laboratory markers. CRP was elevated. Procalcitonin was not commonly elevated. Lactate dehydrogenase was sometimes elevated. This is often elevated in influenza, and influenza, a surrogate marker that I sometimes use to say if somebody has severe influenza infection or not, are LDH and CK, creatinine kinase. So both of those markers should be elevated in severe influenza, and they're not consistently elevated in COVID-19. So a lot of people don't complain of myalgias, for example, muscle aches in COVID-19 infection. So this is a study showing radiographic findings, and a lot of people are talking about this study and others similar to it. So if we just look at the patient characteristics really quickly, again, in this one, it was 50-50, it was an equal split, men and women. But if you look here at the initial test for COVID-19, only 88% were positive in all comers. So even in late disease, not 100% were positive. At some point, though, these patients, by definition, that was an inclusion criteria for this study, they had to have a positive test at some point. And then if we look at findings in the number of lobes affected, 15% had only one lobe. We think of a viral infection as going all over the body, or if we're talking about the lungs, we often think of it as both sides. And it usually is, including influenza or RSV, other viral pneumonias. But in a few cases, it can be unilateral and in only one lobe. So it does make it less likely that they have COVID-19 infection if they only have one lobe and if they only have one side, but only 60% had bilateral lung disease. And this is on CT scanning, which is more impressive than an X-ray. And here you can see findings on CT scanning. People are speaking about these peripheral ground glass opacities. This is another image, again, showing peripheral ground glass opacities. This often happens late in the disease. So I'm not advocating CT scanning as a diagnostic criteria for COVID-19. And I wouldn't get a CT scan just to rule it out or rule it in, because it's a logistical challenge for the hospital. It will use up a lot of PPE, and it will tie down your scanner if you have to do a cleaning of the scanning of the radiology suite after the patient had been in there, using a lot of PPE with a lot of people to help you transport the patients. There's a lot involved there. So we're not recommending taking people for CT scanning. Other things you can do instead, if you're worried about a pleural effusion, you can certainly get an ultrasound or do a bedside ultrasound, or obviously a bedside X-ray is a reasonable thing to do. But even for those, unless it's clinically indicated, you might not want to get it. Again, looking back at bilateral lung involvement in the early stage was only 28%. So keep that in mind, that it's not always bilateral early on. So early on, CT doesn't really help you. And later in disease, you'd probably already have your COVID-19 testing back. So again, that wouldn't help either. So who do we test? This is a challenging question, and we have to ask, what's our acceptable miss rate? Because unless we have enough supply of testing kits and a rapid enough turnaround time on tests, we can't practically test everybody. So at some point, however, we're probably going to move to the time where we're going to test anybody that could conceivably have the infection. But right now, we need to do some risk stratification. I would argue that if somebody has a reasonable alternative diagnosis, for example, if they have pneumonia in one lobe on a plain chest x-ray and they have a sputum, perhaps you can get a gram stain of the sputum and you see some bacteria in it, and their white count is high, perhaps that's much more likely to be a bacterial pneumonia and less likely to be COVID-19. Of course, somebody might ask, what if they have the two? It's certainly conceivable, but again, we have to triage our resources, so we're always thinking about that. And we can certainly help you come up with plans to do that. So other factors to consideration, of course, utilization of PPE. Should we move to droplet precautions from airborne? And most hospitals have already done that because there aren't enough fitted N95s or PAPRs or CAPRs to handle airborne precautions for everybody. Think about cohorting staff. Staff anxiety is a real issue. It's a problem. I've had some facilities calling me, can I just round in the hospital sort of virtually and talk to the staff or host a webinar trying to reduce anxiety, and we can certainly do that. Task shifting is something we have to think about. Can a CNA do some of the roles that a nurse is doing? Can a nurse do some of the things that perhaps a doctor is doing usually in your facility? How can we allow enough task shifting? Can we do some things in the clinic that we would normally not do? Can we do some things at home that we normally would not do? And can we involve retired personnel in the communities? We also have the situation of rapidly changing guidance. So staying up to date, pushing out that guidance, that's a tough job and something that we're on top of, and we can certainly help you stay on top of and reinterpret the guidance for your particular setting. So as you probably have heard, CDC is now recommending moving to droplet precautions where face masks, where N95s are basically not in high supply and we don't have enough fittings. So that's something to think about. Other factors, the healthcare system is searching for places, equipment, and staff to care for patients. Critical access hospitals are sure to be called upon. Rural facilities may be required and will be required to handle COVID-19 in-house. We're going to also be in a situation where we can't perhaps transfer out patients that we would normally transfer out because our referral centers are going to be busy. Keep in mind that rural and critical access hospitals offer the most spare bed capacity in the system. So we have to worry about staffing issues commensurate with that. So Medicare has been moving rapidly to change guidance, fortunately for all of us. So as you probably know, they've waived the limit of 25 beds and the length of stay requirement. This is a blanket waiver for all impacted hospitals. They've also waived the 3-day prior hospitalization requirement for skilled nursing facilities who can now accept a patient directly from an ER. So if you have, for example, a non-COVID patient, let's say a pelvic ramus fracture in an older person who can't go home and needs a 3-day length of stay to qualify them for SNF, you can send those patients directly to a SNF from your emergency department. And we can also perhaps use other facilities, other sources of beds in our facilities to house inpatients now with the blanket waiver. So with that, I'll stop. Bob, did you want to run through some frequently asked questions?
Yeah, thanks, Ramzi. There are a number of questions that I think you've heard and we've heard through the community that I thought maybe you could help us with. One of the things you mentioned during your presentation was droplet versus airborne. So how do you determine when to use precaution for the droplet versus airborne?
That's a good question. So really following CDC guidance on this, but there's a lot of nuances. So we are, when you have an aerosol generating procedure, you definitely want to stay on airborne precautions. So those are nebulizer treatments. So you have to think about those in your outpatient clinics as well as in the ER and in the hospital. Can you use a meter dose inhaler with a spacer, for example, for some of those patients? But that would require an N95, so would intubating a patient. And the questions I'm getting are, what if the anesthesiologist is intubating the patient, but the surgeon's in the room? Does the surgeon wear an N95 as well? And these are nuanced questions that have to take into consideration the level of PPE in your facility and the number of N95 masks. We have staff members that are super anxious and don't want to, for example, go into a room and do a procedure or help with a procedure for a confirmed case if they're not wearing an N95. But if all you're doing is putting in an IV line, you don't need an N95. A surgical mask can do. So that's a tough question. It depends. There's some nuances, but overall, you really want to avoid aerosol generating procedures. And when you do have to have them, you should do them if you can in the negative pressure room, but definitely with the door closed and with an N95.
So you talked a little bit about the PPE with the N95 and when not to use it. What about other PPE? Can you think of other areas that we can discuss on how to manage the PPE?
Yes. So again, back to masks really quickly, we're recommending extended use of masks. So if an N95, for example, or even a simple surgical mask is not soiled, keep it on until it gets soiled. And there are criteria of taking it off, putting it in a paper bag, not a plastic bag, and reusing it, but using gloves and hand hygiene to take it on and take it off. Other PPE, gowns, and gloves, of course. For the gowns, you can also consider washable gowns. So you don't necessarily have to use a disposable gown every time if you're running low. Can you use a long-sleeved washable gown for some of these cases? Absolutely.
One of the things you mentioned in your discussion, I brought up when we first started the webinar, was that as there's an onslaught of cases at the regional medical centers, the critical access hospitals and rural hospitals will be forced with probably keeping patients that they normally would transfer out. Along those lines, and then weaving into COVID-19, what should they be looking at from stock in the pharmacy that they might not be thinking of today?
So good question. There's a lot of medications that have been thought about for treating COVID-19 patients. So we're also going to be treating perhaps other complications. So you have to think about your routine antibiotics, for example, for pneumonias, because we're probably going to have more use of those medications. We have some shortages coming in for everything from oral prednisone in some cases to some injectables, because a lot of manufacturing has happened in China and they've ramped down their production. Hopefully they'll ramp up soon. So we have to think about that. But in terms of treatment for COVID-19, we found that Kaletra has not been very effective. That's an HIV medication. But we also can consider hydroxychloroquine or chloroquine as alternative treatments. And then you have to think about remdesivir, which is an injectable medication that Gilead has produced that's in clinical trials. So some centers are able to get compassionate use for that medication, and we can definitely help with that.
Okay, and then with regard to other patients that might be staying at the hospital that normally would be transferred out, can you think of anything we should be thinking about keeping on at the hospital level now?
Probably just beefing up our routine supplies. I think it depends a little bit on the individual center. Do you have enough imaging equipment? Do you have enough surgical supplies? You might have to do more procedures than you would, some procedures that you would normally transfer out. Do you have enough medical staff to take care of these people? That's telemedicine is great, and it can really help. So, and we certainly can help with any infectious disease related issue. Keep in mind that infectious disease doctors are also internal medicine doctors. So we can definitely help meet some temporary increase in in demand there. But supplies are a tricky question, and it depends again on what we might expect to see in the community.
And maybe look at the previous patients you've been transferring out that you might think you're keeping as far as looking at those supplies.
Exactly.
Last question. In your practice, how do you determine which patients you see via telemedicine versus trying to see in person?
So I do have an outpatient practice a couple of days a week. And if for right now, if the visit can be done by telemedicine, if there's no pressing indication for the patient to come in to the office, I'm doing that via telemedicine. And I think that's a powerful tool, and Medicare has lifted restrictions on doing telemedicine. So they're reimbursing for it, which is great.
Okay. And I guess to finish up, how would somebody get in contact with you if they need to talk to you about any of these issues we've talked about today?
So feel free to reach out. My email is here. It's rasfour@praxis-ID.com. You can reach out or call, go to our website. It has some useful information in terms of contacting us. And you can also reach out to HCI, and they also have our contact information.
Dr. Asfour, thank you so much for spending the time with us today to go through this important information. I know that everybody that gets a chance to watch this webinar will certainly come away with a lot more information that'll help them deal with what we're going through right now in our nation. So just on behalf of HeartCare and all of our friends in the rural community, thanks so much.
Thank you, Bob. Appreciate it.